Cotton, and I am the Center Director for the newly named Osher Center for Integrative Health at the University of Cincinnati. The center aims to improve the health of our community via integrative health and wellness, evidence-based strategies, including things like food as medicine, exercise as medicine, stress reduction, and social connection. This virtual lifestyle medicine and wellness series happens 3 to 4 times a year and is an opportunity for our community to really hear from our expert Osher Center faculty on key topics of wellness. Kelly Lyle, our education program director for the center, will be monitoring the Q&A feature for any questions that you might have for our presenter that come up. So please go ahead and put those into the Q&A, not the chat function. If you put them into Q&A, and we will do our best to address those at the end of the presentation. It's now my distinct pleasure to introduce to you Dr. Jennifer Molano. Dr. Molano is an associate professor at the University of Cincinnati on faculty since 2010, and she is a sleep medicine specialist at UC Health. She completed both her medical school and her neurology residency training in her home state at West Virginia University, and then received training in behavioral neurology at the Mayo Clinic and in sleep medicine at Vanderbilt University. She's a wellness champion for both our faculty, staff, and residents here at the university, and one of the 36 affiliated faculty with the Osher Center. We are so happy and honored to have her here with us today. So please join me in a warm welcome for Dr. Molano.
All right, great. Thank you, Dr. Cotton, for that very kind introduction. And thank you all for joining us today. I'm going to go ahead and share my slides. Let me know if you can see them. Can you see my slides?
Yes.
Okay, perfect. All right, very good. So yes, it's a pleasure and an honor to be here today and to kick off this series, especially as we are entering a new era with our Center for Integrative Health and Wellness as an Osher Center, which is quite a prestigious honor and a great privilege. I am here and tasked to talk about healthy sleep. So what I'll be doing is giving you a very brief overview of sleep, and we'll talk about just about what sleep is, why it's important for health and brain health, and talk about some common sleep symptoms that people have and what we do to manage just a few of those. And then we'll come up and finish up with some practical tips to improve your sleep, as well as open it up for question and answer. So I always tell people that sleep is a necessity. It is not a luxury, and it is an important part of our ability to maintain our ability to function throughout the day as well. One technical definition of sleep is that it's a reversible behavioral state of perceptual engagement from an unresponsiveness to the environment. So I think it is something that is just a part of our normal body functions, and it is very important in order for us to do well and perform well throughout the day. And so other theories behind why we sleep include the fact that it's important for conservation of metabolic energy. We tend to spend less energy during sleep as opposed to quiet wakefulness, so about 15%. In addition to that, we'll talk a little bit briefly about how it's important for our cognition or our brain health. And so what we know is that if we're not sleeping very well, we can have decreased intellectual performance, as well as some other challenges to our memory and our thinking. Again, sleep is important for memory consolidation, and it's also important for regulation of not only our temperature, but also a lot of our other body functions, including our hormones and our heart rate and our breathing, just as examples. And so, I think, one thing that's important to recognize is that sleep is and does affect every single system in our body. So, there are changes that occur with sleep. As an example, our breathing rate tends to slow down, specifically during non-REM sleep, can be a little bit more variable during REM or our dream state sleep. Our heart rate and our blood pressure also decreases during sleep as well. And in addition to that, as we mentioned before, lots of different hormones fluctuate up and down throughout our sleep-wake cycle and can be affected by our sleep as well. So a couple of hormones that may be sleep mediated or affected by sleep or sleep deprivation, as an example, include growth hormone, which has implications for children. And then our thyroid hormone is also partially mediated by our sleep as well. So if we're not getting enough sleep, then our TSH, or our thyroid stimulating hormone, may elevate or increase, just as pure examples for that. And sleep health is so important that the American Health Association just recently, within the past couple of weeks, put it in as a part of their essential eight activities or items that are important for cardiovascular health or heart health. So in addition to a healthy diet, physical activity, and making sure that you're not smoking and having, your blood pressure is under good control, as well as your blood sugars and your lipids and cholesterol as well. Sleep and sleep health has been recently included as a part of that essential eight. It used to be Life's Simple 7, now it's Life's Essential 8, with sleep health being the newest addition to that portfolio for essential sleep health or cardiovascular health. So one of my particular interests, of course, as a neurologist, and especially as a behavioral neurology fellowship trained neurologist who also specializes in sleep, is that we're also finding out more and more that sleep is really critical for brain health. So if we sleep well, it allows us to pay attention to things. It allows us to have optimization of what we call our executive functions. So those include our ability to make decisions, to multitask, and to plan activities. Sleep is also very important for learning. So being able to encode our memories. So helping us to store our memories into that long-term storage in our brain. And then the other critical piece that sleep is important for is helping with managing our emotions. So managing our emotions and attention, executive functioning, learning, a lot of that deals with our frontal lobes, so the front part of our brain. And so if we're able to sleep well, we're able to regulate our emotions, not be very, be able to kind of make decisions that are prudent and sensible. And so it's very important for us to be able to sleep well, have good sleep quantity, good sleep quality, and we'll talk a little bit more about how to do that in a few minutes. But I think there's also emerging evidence that sleep is critical for brain health, because one of its newer functions or newer found functions is that sleep may help to sweep toxins out of the brain. And so this has potential implications with conditions such as Alzheimer's disease. So there have been many emerging studies that have shown that if someone does not sleep well, that it can contribute to the emergence of a potential Alzheimer's disease pathologies in the brain. So again, sleep is a necessity, it's not a luxury, and it's very important for us to make sure that we're aware of that. And so talking about kind of what drives our sleep-wake cycle, the way that I kind of think about it is that the sleep neurobiology, I think, is quite fascinating. But what I tell people practically in the clinic is that our sleep-wake cycle is driven by two main processes. So one is what we call our homeostatic sleep drive, and the second is our circadian alerting signal, or our internal body clock. And what I tell people is that assuming that someone has adequate duration and adequate quality of sleep the night before, and adequate duration for people between the ages of 18 to 65 is 7 to 9 hours of sleep. For those over the age of 65, it's 7 to 8 hours of sleep. What happens is that when we first wake up in the morning, and again, assuming adequate sleep quantity and quality, our homeostatic sleep drive is weakest when we first wake up, and it gets stronger and stronger and stronger and stronger throughout the day until our internal body clock tells us to sleep at night. Our internal body clock is driven by a structure in the brain called the suprachiasmatic nucleus. It's kind of our master conductor. What happens is that when it is light outside, what happens is that melatonin is suppressed in the brain. And then when darkness occurs, then melatonin gets released, and that helps us to fall asleep at night. In addition to that, and I'm not going to go into full detail on this, but I just want you to appreciate that there are neurochemicals or neurotransmitters in the brain that are important for not only helping us to fall asleep at night, but also helping us to stay awake. And this has potential implications in terms of medications that we might take that can potentially affect our sleep-wake cycle. So now, how is sleep organized? So some of you may know that we have kind of two big sections of sleep. So we have non-REM sleep and we have REM sleep. REM stands for rapid eye movements, and that's usually our dream state sleep. And non-REM sleep can be further categorized into N1, N2, or N3. So otherwise known as our lighter stages of sleep, our intermediate stages of sleep, and N3 being our deeper stages of sleep. One sleep cycle tends to be about 90 to 110 minutes, and it tends to be repeated about 4 to 6 times a night. And what tends to happen during a normal night of sleep is that we have the highest percentage of our N3 or slow wave sleep during the first part of the night. And then we have our largest percentage of REM sleep during the second part of the night, or kind of closer to when we're about to wake up. Young adults spend about 50 to 60% of the night in that stage 2 or intermediate stages of sleep. REM is approximately 20 to 25% of the night, and then we spend about 15 to 20% of N3 throughout the night as well. On the right hand of the slide, what you see is kind of what happens to sleep throughout the lifespan. So this is what these small graphs are what we call hypnograms. So it's a compression or schematic of one sleep over one night. And on the x-axis, what you see here is the number of hours in bed. And then on the y-axis here, what you see are the different stages of sleep. So wake, REM, N1, N2, and N3. What I want you all to appreciate here is that there are natural changes that occur throughout the lifespan as we get older. So as an example, when we are children, or children in general, have the highest percentage of slow wave sleep. As we get older, what tends to happen, especially as we get over the age of 65, is that we tend to have less slow wave sleep as we get older, and then more nighttime awakenings, just as a part of the normal aging process. So just wanted to appreciate that there are, again, these normal processes that can occur throughout the lifespan. So now I give you an opportunity, and I give you a chance to kind of get a brief assessment of what your sleep health might be like. So this is just a very brief questionnaire called the SATED questionnaire, where we just basically get an assessment of your sleep health. So you can tally this up on your own and ask yourself, S, are you satisfied with your sleep? So the answers are rarely or never for 0, sometimes for 1, usually or always as a 2. Alertness, do you stay awake all day without dozing? Again, rarely or never 0, sometimes 1, usually always 2. Timing, are you asleep or trying to sleep between 2 and 4 a.m.? Again, rarely or never, sometimes, usually or always. Efficiency, do you spend less than 30 minutes awake at night? And this includes the time it takes to fall asleep and awakenings from sleep. And then duration, do you sleep between 6 to 8 hours during the day or at night, ideally at nighttime? And so what you do is you just do a brief tally of those scores. The range goes from 0 to 10. And if you're towards the end of 10, that indicates that your sleep health is pretty good. If it's more towards 0, it's a little bit more suboptimal, and there's some areas for improvement. So what exactly happens if you don't sleep well? So if you don't sleep well, some people may feel fatigued. There are studies that have shown that people take longer to make decisions, so their response times are lower. They have more errors, and they have reduced learning or flexible thinking. So if things are kind of coming to you all at once, it's a little bit more challenging to try and shift your attention from one thing to another. There's also increased risk taking. So what happens sometimes when people are sleep deprived is that they might have more maladaptive behaviors, such as drinking more, as an example, drinking alcohol more, to clarify. And then higher emotional dysregulation. So I know for me, if I don't sleep very well, I'm very grumpy, and it's hard for me to concentrate. And it's very hard for me to kind of reset and regulate my emotions if I'm in a pretty challenging sort of situation where I need to be. And then decreased resilience. So our ability to kind of bounce back from setbacks and challenging situations can be a little bit more of an issue. So what are some common sleep symptoms that we see? So a lot of times what we see in the sleep clinic are people are either they're having problems falling asleep, staying asleep, having insomnia, or they may have too much sleepiness during the day or hypersomnia. And in addition to that, they might have unusual behaviors when they sleep at night as well. We'll go over briefly kind of what causes some of these things to happen. So again, common sleep symptoms for us include insomnia. And so a lot of times people think of insomnia as problems falling asleep, but we also consider insomnia to be difficulty staying asleep. And then sleeping too much during the day. So this idea of hypersomnia or daytime sleepiness. Lots of different things can cause sleep symptoms. So underlying medical or psychiatric conditions may contribute. Medications, again, since we talked about how there are different neurotransmitters that are associated with our sleep-wake cycle, medications certainly can contribute to sleep symptoms. Environmental and behavioral factors. So, sometimes having too much light, or if they're in a noisy environment, or, if their bed partner is snoring. Those are some common things that we hear a lot in terms of environmental factors. And then behavioral factors. Sometimes what can happen is that if someone needs to stay up late at night because they're trying to get a work project done, but they have to wake up very early in the morning, they might not be getting a sufficient amount of sleep. And as a result of that, might be sleepy during the day. And then primary sleep disorders. One example here is obstructive sleep apnea, but we have a whole book of primary sleep disorders that may contribute to sleep issues. And we'll touch on it, just a few of those here today. So in terms of insomnia, problems falling asleep or staying asleep, again, as we mentioned, lots of different things may contribute to that. Inadequate sleep hygiene or having unhealthy sleep habits may also contribute to insomnia, and we'll delve into a little bit of that in just a few slides. And then we talked about environmental factors and primary sleep disorders as well. In terms of insomnia and chronic insomnia, again, lots of different things may contribute. Some of the medical issues that may contribute include pain. Asthma, as an example, is one condition that tends to be exacerbated during sleep. Mood and anxiety disorders. So if someone is having anxiety, as an example, they may be at a more sort of hyperarousable state, so that they might be just a lighter sleeper as a result of that. And people who have depression, as an example, may have insomnia because they wake up early in the morning, so those early morning awakenings. And then the primary sleep disorders, one of the ways that people can present with obstructive sleep apnea is that they're having problems with sleep maintenance, so waking up frequently during the night, or they may have nocturia, so they may need to urinate multiple times throughout the night, as examples. In terms of insomnia treatment, in an ideal world, it's best for medications to be used from a short-term use only, so primarily about 3 to 6 months. For those who have other comorbid or other medical conditions, sometimes chronic use may be beneficial. So there are some antidepressants and some anti-epileptic medications that may have sedating side effects. But studies have shown that the gold standard for treating insomnia tends to be more of the non-medication strategies. And so we'll talk a little bit about that in these upcoming slides here. So one of the mainstays of insomnia treatment is what we call cognitive behavioral therapy. So the cognitive piece is trying to identify and correct negative thinking or thoughts associated with sleep. A lot of times people may have insomnia for such a long period of time that they're afraid to go to bed because they feel like they're not going to be able to sleep, as one example. In terms of the behavioral aspects of it, this is where sort of the good sleep habits sort of come into play. And also, making sure that, someone's sleep schedule is one that's regular and consistent as much as possible. I emphasize the sleep habits here because it has a direct effect in terms of that sort of those drives to help us fall asleep at night. So one of the reasons why we should practice good sleep habits and have a good sleep foundation is because of this sort of homeostatic sleep drive and this circadian rhythm, this two-step process that helps us to stay awake during the day and helps us to sleep at night. And so, as we recall, we want to have regular sleep duration, good sleep quality, so that these two systems and processes can work in concert together to make sure that when we're alert and awake, we are able to function during the day, and then when we want to sleep at night, we're able to do that. And so it's all about the homeostatic sleep drive and our circadian rhythm. The brain likes consistency. I think that's one of the things that I like people to understand and recognize. So in terms of our homeostatic sleep drive specifically, remember what I said is that our homeostatic sleep drive is weakest when we first wake up in the morning and gets stronger and stronger and stronger and stronger throughout the day, so that when we sleep at night, we're able to fall asleep. The two things and two behaviors that can directly hinder our ability to fall asleep are, number one, caffeine, and number two, taking naps during the day or prolonged naps during the day. As an example, caffeine is what we call an adenosine antagonist. So adenosine is kind of a chemical that kind of is associated with that homeostatic sleep drive. And caffeine directly decreases the amount of adenosine in our bodies. So hence the word adenosine antagonist. Caffeine has a half-life of about 3 to 5 hours. So in other words, if you are consuming a caffeinated beverage, 3 to 5 hours after you last consume it, there's still about half of the caffeine that's in your system that's kind of trying to keep you awake. So as a result of that, we tend to make the recommendation to not have any caffeine after 2 o'clock in the afternoon to try to optimize your ability to fall asleep at night. In terms of naps, there are people who have power naps. I actually am a power napper, but my naps tend to be about 15 minutes or so. But if you take prolonged naps, so naps over 30 minutes a day, what tends to happen is that you can directly steal from your sleep at night. So as a result of that, if you're sleeping for 1 to 2 hours during the day, you're stealing that 1 to 2 hours for sleep at night. And oftentimes what we hear is that people may be able to fall asleep, but then they wake up in the middle of the night and then they can't fall back asleep for that 1 to 2 hours. So again, trying to have no caffeine after 2 o'clock, trying to minimize or eliminate naps during the day helps that homeostatic sleep drive to be the strongest as it can be when we're trying to sleep at night. So we talked a little bit about how that can happen there. So in terms of other non-medication strategies to help us fall asleep, I think the other thing, eliminate naps, minimize them as much as you can, no caffeine after 2 o'clock, maintain that consistent sleep schedule because the brain likes regularity. And the other two things that we focus on are what we call stimulus control. So keeping the bedroom for sleep only. What I tell people is that if you are having difficulties falling asleep and staying asleep and you're lying in bed and you're thinking about things, or you're watching TV, or you're looking at devices and the devices have that bright light that can keep us awake through that circadian rhythm, then what you're doing is that you're actually training your brain that that's okay. And then it can contribute to and feed into the insomnia. So what we tend to tell people is that if you're having problems falling asleep or staying asleep within 20 minutes, ideally what one person should do is physically get out of bed, go into another room and do something that's relaxing, or we like to say boring. If you are going to read, we recommend not reading mystery novels or anything that will keep you activated. I've had people tell me that they will read mystery novels and then they can't go back to sleep, as an example. And then relaxation training. A lot of the things that we do in the integrative, the Center for Integrative Health and Wellness is a lot of that, those mind-body sort of skills. So relaxation training can be a part of that. So tensing and relaxing various muscles in the body. And the whole goal of that is to try and decrease and kind of calm down our system so that we can sleep at night. In terms of sleeping too much during the day, one of the common symptoms that we see is, one of the common causes for that is obstructive sleep apnea. And of course, as we mentioned before, underlying medical, psychiatric conditions, medications, inadequate sleep hygiene all can contribute to that. Narcolepsy is another condition that we see that can contribute to hypersomnia or daytime sleepiness. This sometimes is associated with cataplexy, where people lose muscle tone in response to some sort of emotional event, or they can have sleep paralysis or hallucinations either as they're falling asleep or as they're waking up. But we'll delve a little bit more in obstructive sleep apnea, since this is a very common thing that we see in the sleep clinic. It's seen in about 5% of the population, but can increase as we get older. It is associated with obesity, heart disease, lung disease, more common in males, but also can be seen in females, of course. And one of the common symptoms that we see for that is snoring, but people can also have morning headaches. They can stop breathing when they sleep at night as well. With obstructive sleep apnea, what tends to happen, and the schematic shows that, normally if we're trying to breathe normally during sleep, ideally we want our airways to be open. But what happens with obstructive sleep apnea is that our airways may close up, and sometimes that may be due to the relaxation of our muscles, including our tongue muscles, as an example. It is a risk factor for high blood pressure, car crashes, difficulties with thinking, stroke, and heart disease, and has other implications regarding other health and socioeconomic consequences as well. How we evaluate for sleep apnea is by doing a sleep study. A lot of times I have a lot of people who tell me, I snore, but I do not have sleep apnea. And I tell them, I do not know if you have sleep apnea because I don't have the data. And we need that objective data in order to determine that. There is a home sleep study, which is just looks for sleep apnea, but this comprehensive sleep study, what you see in this schematic here is something that we actually see if you spend the night at our laboratory. So those are sensors on the head to see what the brain waves are like, sensors around the eyes, the chin, and the legs to see what your movements are. And that helps us to determine whether or not you're awake or you're asleep. There are breathing parameters. So we look at a sensor underneath the nostrils to see the airflow, a probe on the finger to see if your oxygen levels are dropping, and then some bands across the chest and the belly to see how much effort you make when you sleep at night. A home sleep study really just looks at the breathing parameters. So it doesn't look at your brain waves and it doesn't look at your movements. And it really kind of sometimes depends on your other medical issues as well as your insurance in terms of which study we are going to get for this to evaluate for sleep apnea if needed. Our common cause or common treatment for sleep apnea is CPAP, or continuous positive airway pressure. It's a device that is hooked up to a mask that pushes, and that device pushes in room air to open up the airway spaces. If people are unable to tolerate that, and CPAP is kind of our first line treatment and gold standard in terms of treatment, but depending on how severe one's sleep apnea might be, they may be one may be a candidate for alternative treatments. So some of those include an oral appliance, which is a mouthpiece that is fitted by a dentist, and it pushes the lower jaw forward to open up the airway spaces in the back. There's positional therapy options, such as the Zoma device, which is on the right, which is FDA cleared, but not covered by insurance. But the whole point of that is if someone on a sleep study has more blockages of their airway when they're on their back, the goal is to try to keep them on their side. And then there are surgical options, as you can see on the left. One example is called Inspire, which is an implant that's surgically implanted by an ear, nose, and throat doctor. And what it does is that it stimulates the nerve to the tongue and to protrude the tongue forward and open up the airway spaces. So there are alternative treatments if people need them and are a candidate for them for sleep apnea if they cannot tolerate CPAP. So other sleep disorders. One other common sleep disorder that we see is restless leg syndrome. So this is actually something that one experiences. So it has 4 specific criteria. So it's an urge to move the legs that's worse at rest. Urge to move the legs that's at night, worse at rest, and better with movement. And in order to make that sort of characterization and diagnosis of restless leg syndrome, one has to have all 4 of those criteria. It have to exclude other things that may contribute to leg issues, such as leg cramps or positional discomfort. And then in terms of management, there are both, again, non-medication ways as well as prescription medication ways of doing it, for treating it. One of them is to check iron status. And the reason why we check iron status is that the thought process is that restless legs is due to a drop of a neurochemical or a neurotransmitter called dopamine that drops in the evening, and iron is important in order to make dopamine. So if someone has low iron stores, then try iron supplementation can be helpful. And then, trying to wean off of caffeine, reviewing medications, because there are a number of medications that can contribute to restless legs. And then try to maintain mentally alerting activities during the day as well. There are medications, again, that can be used in order to treat restless legs. I think some of the ones that we usually use are ones that kind of help to boost up the amount of dopamine in the system. One caveat with those is that it can cause quirky side effects, such as that can be more of a tolerance effect. So you can have earlier restless legs symptoms during the day, as an example, or can spread into the arms. And then impulse control issues. So overeating, overspending, is something that we sometimes can see with these people who are on these medications for a long time. There are other medications such as gabapentin or pregabalin, which can help with restless legs. And then in refractory cases, sometimes low dose opioids may be helpful, but we try to use those very cautiously. In terms of some other symptoms and other sleep conditions that we may see, sometimes we see people who have parasomnias. So this is an umbrella term for kind of unusual behaviors at night. So this includes our sleepwalkers, our sleep talkers, and even people who may act out their dreams at night. And then circadian rhythm disorders. So sometimes what we see are people who have problems falling asleep and staying asleep, or falling asleep and being sleepy during the day because they're extreme night owls. So are what we call delayed sleep phase, people who have delayed sleep phase syndrome. So these people they're trying to go to bed at midnight or 11 p.m., but their body clock is telling them to fall asleep at 4 o'clock. And then they have to wake up at 8 o'clock in the morning for work. And as a result of that, they may have sleep onset, and then they are tired during the day. But some tips to improve sleep in this very brief overview is, just the following. So maintain a consistent sleep schedule. So again, our brain and our body likes regularity, likes routine, likes to know when it's supposed to fall asleep and when it's supposed to wake up. Have a bedtime routine, ideally 30 to 60 minutes before you're supposed to go to bed, and aim for 7 to 9 hours of sleep. We want to review your medications, and if you have any other medical or psychiatric conditions that may be contributing, try to limit naps to no more than 30 minutes a day. No caffeine after 2, avoid nicotine, which is activating, and alcohol, which may help people fall asleep, but then wears off and then can contribute to frequent awakenings throughout the second time of the night. And then maintain the bedroom for sleep only, and keep a cool, comfortable environment. So with that, that's my very, very brief overview on sleep medicine and sleep and healthy sleep. And that, I think we will open it up for question and answer. Dr. Cotton, did that work?
Yeah, thank you so much, Dr. Molano. That was incredible. There are several questions that have come in through the Q&A, another few through the chat. Please try and put them in the Q&A section. I'm going to let Kelly Lyle go ahead, who's been monitoring that, and highlight a few of the questions for you. So Kelly.
Yes, thank you so much, Dr. Molano. That was so educational. There's a couple questions here that I think are very relevant to the audience, such as any recommendations you have for second and third shift workers.
Yes, I was actually going to mention that. So, you know, as a part of the circadian rhythms, what happens with our shift workers is that, you know, you are basically working when your body's telling you to sleep and vice versa. So what we typically recommend for our shift workers is that if you are going to consume caffeine, try to consume a caffeinated beverage during the first half of your shift so that it can wear off, so that when you go home, you're able to, you know, try and sleep as much as you can. As you're going home, if you can, try to wear the dark glasses so that the sunlight, which again, you know, triggers us to stay awake through that internal body clock or circadian rhythm. You know, try to keep, you know, try not to expose yourself to bright light as much as possible is very important. And of course, have those sort of like blackout shades at home as well is important as well.
Okay, thank you so much. And then there's another question here. I know there's a lot to answer with this, but what can I do to calm my brain so that it's not always racing at night? I'm sure all of us have that.
Yes. So I think, you know, one of the techniques they also talk about are just sort of just basic relaxation techniques. One thing that we sometimes do, and I've had some people say has been helpful and personally is helpful for me, are just the deep breathing exercises. So, you know, again, just kind of taking a slow deep breath in and a slow deep breath out, you know, a few times can sometimes help to reset your brain. And again, if you're having difficulty calming your brain because you're thinking about things, some other strategies that have helped me and others is actually, again, within that 20 minutes, physically getting out of bed, going into another room, and even sometimes just journaling. That can sometimes be helpful as well.
Okay, awesome. Thank you. And then Robert has a good question here. I have read that eating before bedtime is not a good idea. A person needs to stop eating any meal at least 3 hours before going to bed. True or false?
Yes, I think my husband can attest to this anecdotally. If he sleeps too late, if he eats too late, he can't fall asleep. Yes, so I think in terms of that sort of regularity, I think what happens is that if you are eating too late, what can happen is that your body is focusing on trying to digest your food and not helping you to focus on trying to go to sleep. So trying to, you know, regulate the time and have you know, enough time for you to digest before you go to sleep is important. The other thing too is that if you're eating too late, it can contribute to other things that may contribute to sleep issues such as heartburn. So if you're eating too late, sometimes you can have those sort of reflux symptoms that may contribute to sleep issues as well.
Okay, and this is an interesting question. Is it usual to have hiccups wake you up during sleep? What would cause this?
Oh, that's an excellent question. I do not have the answer to that one, unfortunately.
Okay. Oh, here. In regards to therapies, if you are unable to tolerate a CPAP, what other options are there for you?
Right. So again, what I mentioned, so there are 3 potential avenues. So one is sort of the oral appliance option. So that's best for people who have mild to moderate obstructive sleep apnea. So for people who have 5 to 15 blockages of their airway per hour, as an example. So that's fitted by a dentist. It pushes the lower jaw forward and opens up the airway spaces. Inspire is a surgical option that is implanted by an ear, nose, and throat doctor. It stimulates the nerve to the tongue and protrudes the tongue forward to open up the airway spaces. And then there are positional therapy options, you know, trying to keep someone sleeping more on their side if someone has more abnormal or blockages of their airway when they're sleeping on their back.
Okay. Here we go. What about exercise before sleep? Should it be limited, or what's the best option there?
Yeah, there's a little bit of debate in terms of when's the best time to exercise. I think the common recommendation is to try to exercise. If you're going to exercise in the evening, try to make it like earlier in the evening, as much as you can. I think part of it too is that whole, after you exercise, your body has to kind of, again, reset and recalibrate. And so if there are things that are sort of keeping someone activated from that, or if you're still in the process of doing that after exercising, then it's harder for your body to kind of get that rest and, get that reset that is needed in order to sleep at night.
Okay. Okay, I'm going to ask like 2 more questions here. This one I think is super interesting because I just think it's super interesting. I use Fitbit to track my sleep. I get scores of 90 frequently. Is Fitbit a reliable tool to track?
This is an excellent question.
Uh-huh.
I think, I tell people that the wearables, be it Fitbit, Apple Watch, or whatever, there are rings now that tell you, that when you're sleeping and when you're waking. I tell people to use that data with a grain of salt. I think they can be very helpful for giving you an estimate in order of like how many hours of sleep you're getting, what your sleep quality may or may not be like. Where it's not quite as robust is in terms of determining what stage of sleep you're in. So if you recall, in order to determine the stages of sleep on a sleep study, we need brain waves. We need our brain waves to see what our brain waves are like. We need to look at our movements of our eyes, our chin, and our legs. So those are things just to kind of keep in mind. I also tell people it's also important to see kind of how you feel in the morning. If you're feeling great, then, it's good. But if you're, don't focus so much on the data. So sometimes people can actually get anxiety and have difficulty falling asleep and staying asleep because of the because they're so focused and fixated on the data. So take the data as an estimate, not as the holy grail, and use it with a grain of salt. So that's it. And then I did see one question about Benadryl. I did want to address that. Okay. So just from a brain health perspective, Benadryl has properties that decrease the amount of what we call acetylcholine in the brain. And acetylcholine is a really essential neurotransmitter, neurochemical for attention as well as memory. And so if you talk to my cognitive colleagues, Benadryl and actually a lot of our other sleep medications can potentially cause long-term cognitive effects on the brain. And so, we try to recommend trying to limit that as much as possible.
Dr. Molano, thank you again. Before I wrap up, because I know there are still a lot of questions, but we want to be mindful of time, what would be your number 1 or maybe 2 top resources for people to go to? So there's questions about daytime sleepiness, additional behavioral strategies for falling asleep when your young kids wake you up. Do you have a top 1 or 2 recommendations, either books or websites for folks on the line?
Yeah, so I think the American Academy of Sleep Medicine's patient-facing website is sleepeducation.org. So I would recommend that people go to that website for just general information. And then, the other one, I tell people, the book that I tend to tell people to read, which was recommended by my mentor at Vanderbilt for insomnia, is Say Goodnight to Insomnia. So those are 2 sort of resources that we recommend as well.
Great, thank you. We'll make sure we actually put that on our website for people and in our follow-up materials so people have that available. So again, I really want to thank you, Dr. Molano, and the almost 100 people that were with us today. We invite you to stay engaged with the center, sign up for our e-newsletter. Our next session actually in this series is going to be with Dr. Mladen Golovich, our medical director, on October 20th at 6:30, doing a program on food as medicine, farm to pharmacy, spelled FARMACY. Again, if you have any other questions, please come to our website, med.uc.edu/integrative. You can always email us at our new email, osher.integrative@uc.edu. We wish you a wonderful day, wish you a wonderful night and week and month and year sleep. Thank you to Dr. Molano again and to Kelly for moderating, and we'll see you all next time. Everyone stay well. Take care.